Bismillahirrahmanirrahim. Assalamu alaikum. Treatment of psychotic and bipolar disorders. When a patient or client approaches you, and here in our context, it's mostly online or through the phone, however it works out, we have to observe the core conditions of counseling at all times. The core conditions of counseling involve empathy, congruence, and unconditional positive regard. I know many of us or all of us have studied this as part of our work on counseling. Empathy is to really put yourself in the shoes of the person, try to reflect what the person is saying. Congruence means being genuine. He should see you as a genuine person, not faking something. And the third one is unconditional positive regard. It is a regard where you accept the person, and it's the love of a non-sexual kind where you really care about the well-being of the person. These are the core skills of counseling that must be observed at all times. Then we got to the advanced skills. I will just to name a couple. You must practice and must be observed and videotaped how you actually, utilize these advanced skills. They should be, really tuned and developed. So, reflection of meaning and content, and reflection of feelings. Meaning and content, you must be able to fully understand it and reflect it back to the person as best as you can, and the person's approval, nodding or saying like exactly or something, will show that you have been able to reflect the meaning or content of what he or she is saying accurately. Feelings is obviously the core of everything, which usually is not that easy to reach, especially with manic or major depressive patients. It may come not so easily. All right, so early intervention. After the first episode of psychosis, where a person starts hearing things or seeing things or breaks contact with reality, the medical team, which is approached, this person approaches the patient, or a group or like a family brings a patient to you, you must conduct a full assessment of the patient's needs. Medication, it may be something like antipsychotic drugs or mood stabilizers that may be needed, which is the work of a psychiatrist, a medical doctor. Then the medical team must also refer the patient to for psychological therapy, a counselor who will mostly use CBT, cognitive behavioral therapy. We'll get to that. And also, as part of the treatment, as part of the treatment planning, social, occupational, and educational interventions must also be looked into, which in one word, family should be involved at the first step as part of the plan. They should be explained what is going on, like providing psychoeducation, what the disorder is, what it means, what it does, and how can you provide supportive care and help the person who is experiencing these problems. All right. So, psychological therapies, cognitive behavioral therapy, I'm quoting, for psychosis is based on an understanding of how people make sense of their experiences and why some people become depressed by them. You will try to interject, have the person, basically the patient, test his hypotheses, the assumptions, and try to bring more realistic thoughts in his way of how he or she processes information from the environment. Uh, so, how to proceed with the counseling? So, a person comes to you, and you will ask, "How can I help? What brings you to counseling?" उर्दू में ही बात करेंगे, ज़ाहिर है। आप मोस्टली तो आप पूछेंगे कि आप क्या मैं आपकी हेल्प कर सकता हूँ, क्यों आप यहाँ आए हैं, क्यों आपने कॉल किए, So what you are doing is you are from the very first line you are trying to zoom in on what is the ultimate goal, what is the primary concern, so that that concern will translate into some form of goal for treatment, and that goal should be broken down into more easier to achieve objectives, and those objectives should be as we will mention specific, realistic, and measurable. Okay, so how can I help? Then you listen with empathy, utilize those basic and advanced skills of counseling. Listen with empathy, and keep summarizing after every few, like a person, the patient is able to describing, and you are reflecting. After some reflections, you summarize what has happened so far for the patient or family. Determine long and short-term goals of therapy. When the discussion is going on, you will ask obviously with a manic patient or a hypomanic patient, it may not be easy. Manic patient is completely out of touch with reality, so you may not go very far with all these procedures I'm describing. But with hypomanic, because the person has not broken contact with reality, you may be having a better a more directed conversation. But with manic patients also, there's a video I have posted here. I would like you all to watch with a manic patient. Okay, set objectives that are specific, realistic, and measurable. To get to that goal, what is the goal of therapy? Goal is, I will describe, and I don't want to repeat. Okay, jot down a treatment plan. After setting the goal, objectives, and the plan to execute, you sit down and make your own treatment planning, because you'll probably be seeing this patient again next session. You should know how to continue, what is the follow-up, which way to go. Let me describe a brief story about a triple divorcee, one of the classic examples of bipolar 1 disorder. So I will try to make it as short as I can. Sandra Kovacs, a 37-year-old thrice divorced woman who works as a paralegal in a prestigious law firm, was hospitalized in a psychiatric hospital because of an attempt to end her life by taking an overdose of sleeping pills. She reported that about 3 months ago, after her chronic mild depression had gotten worse, her psychiatrist switched her antidepressant from citalopram, a selective serotonin reuptake inhibitor, to desipramine, an older tricyclic antidepressant. The medication was changed basically. Within a few weeks of starting the new medication, Ms. Kovacs reported feeling more energetic and confident at work, and requested additional assignments from the law partners. Feeling like she no longer needed to be on an antidepressant, she discontinued the desipramine without telling her psychiatrist. Over the next several weeks, she continued to feel like she was on a cloud nine, felt that her thoughts were racing, and found that she could get by on only a couple of hours of sleep. She regularly stayed at work until midnight and went into the office on weekends as well. Ms. Kovacs reported that everything came to a head at a retirement party for one of the partners at the law firm 3 days before her hospital admission. She went to the party feeling wired, hyper, and supersexual. She was telling racy jokes in a loud, boisterous tone and speaking very rapidly. She ended up coming on to the husband of her boss. She even wrote her telephone number down on a napkin, gave it to him, and insisted that he call her after the party. When she groggily woke up the next morning, she realized what she had done and felt that she could never go back to the office and face anyone. Despondent over having ruined the best job she ever had, she took the entire bottle of antidepressant pills along with a bottle of sleeping pills. After Ms. Kovacs did not respond to repeated telephone calls, her mother went on went to her apartment where she found her daughter and called the police, 911. Ms. Kovacs reported that she had suffered from episodes of depression over since her 20s. Her first episode of depression, that is, at age 23, had been triggered by marital separation, but she could suggest no explanation for subsequent episodes. I just seemed to sink into a gloomy despair, although her depression responds at least partially to treatment, with her mood lifting to the point where she can go back to work and function fairly normally. Her mood never completely gets better, and she also feels at least somewhat depressed between episodes. Over the years, she has received intermittent individual psychotherapy, counseling, as well as some small doses of all kinds of antidepressant medications. She has not had any prior episodes of elevated or irritable mood, but notes that her maternal uncle had been diagnosed with manic depression and was in and out of psychiatric hospitals for much of his life. Okay, I don't want to go into all the description of how the diagnosis was made, but she was given the diagnosis of bipolar 1 disorder, current episode manic, moderate. All right, this is just one of the cases that could be described. I have many to share with you, but there's really no time right now. Okay, so I wanted you to look at in this slide, if you can read it, because it will be posted, but it may be very small. So if you could get hold of the actual PowerPoint and read it. The behavioral definitions for individuals with manic and hypomanic problems. Reduced attention span. The video posted right after these two slides is of a manic patient being interviewed by a counselor. You can see all these symptoms right there. Reduced attention span and becomes easily distracted. Impulsive, pleasure-oriented behavior without regard for painful consequences due to loss of normal inhibition. Strange dress and grooming. Expansive mood that can suddenly turn to impatience and irritable anger if behavior confronted. Lack of complete projects, even though energy is high, but lacks discipline and goal directedness. Okay, pressured speech or loquaciousness, talkativeness, flight of ideas or racing thoughts, persecutory or grandiosity beliefs, very little need for sleep, increased motor activity. Okay, all of this. So then I've posted this video. It's from YouTube. It's very, I think, very informative, educational. All right. So you, out of these behavioral definitions, you want to set some long-term goals and short-term goals for manic and hypomanic patients, right? So you want to lower the level of psychic energy and return to normal activity levels. It's not going to happen just by your talking to the patient. Obviously, it needs medication, because we are talking about patients who have who need that. I mean, right away. Lower, sometimes very high doses of mood stabilizers or antipsychotic drugs. Lower levels of psychic energy, return to normal activity levels, increase good judgment, stable mood, and goal-directed behavior. Reduce agitation, impulsivity, and pressured speech. I'm describing the long-term goals. That's your goal of treatment. Increase sensitivity to the consequences of behavior and having more realistic expectations. That's what you want in the patient. And the patient should understand that he or she wants to get there. Explore underlying feelings of guilt, fears of rejection. See the feelings. It's going to be a tough job getting to this level. Explore underlying. You must get the patient to explore what is happening, how is he feeling or she feeling about it, fears of rejection, low self-esteem, dependency, and abandonment. All of that must have or could have happened in the patient's life, and or maybe perceived as happening, that a patient thought he's being abandoned or she's being abandoned, may not really have been abandoned, but all right. So yeah, and then short-term goals. So shorter. Accomplish mood stability. For now, what do you want to do in this next few sessions? Accomplish mood stability, having lower reaction with anger, less expansive, being more socially appropriate and sensitive, encourage expression of grief, fear, and anger regarding real or imagined losses in life, differ between real and imagined losses, accept the level of low self esteem and fear of rejection that underlies that behavior, identify and list the causes for the low self esteem and abandoned fears, stop or reduce self destructive. Uh, I think I lost the page. Okay. Yeah. Stop or reduce self-destructive behaviors such as promiscuity, substance abuse, and expression of over hostility or aggression. Short-term goals continued. Learn to speak more slowly and be more subject-oriented. Learn to dress and groom in a less attention-grabbing manner. Express the acceptance of dependency needs. Identify and list positive traits. Lower grandiose statements. I am so great. I am the best. I am talking to God. God is talking to me. Learn to be less agitated and distracted and be able to sit quietly and calmly for 30 minutes. Agree to sleep about 5 hours or more per night. So determining objectives that are the short-term goals are the objectives. Determining some of these, there are many, but there's some like bring it down to like some achievable 5 or 6 objectives. You will sleep at least 5 hours a night. You will, be able to sit quietly and calmly for, let's say, 30 minutes in a row. Lower whatever those other things I've described. All right, so watch that video carefully till the end. What happens at the end? The irritability shows, in the end of the session. And so to a person to introspect oneself when he has come to counseling and has experienced a recent, psychotic episode or something like that, it's not going to be easy. So you must make sure that there is medical assistance care provided to this patient, and then you have to determine some goals and continue observing the basic and advanced skills of counseling, which should be you should rehearse those with somebody before you actually take a call. Try to practice providing empathy, congruence, and unconditional positive regard, and reflection of feeling, meaning, content, and feeling. It should become that's what a counselor does. So I really wish you well, and I hope this video was not too long. This too much information. I had to make it as short as I could. Thank you very much.